Yes.
Okay.
Good morning and good evening, fellow doctors and colleagues. For today's Dr. Sheng-Po last retirement virtual webinar, we are honored to introduce Dr. Kyung-Hwan Kim as our invited speaker. Dr. Kyung-Hwan Kim graduated from Seoul National University College of Medicine in 1972. He finished his residency on training in the Department of Otolaryngology, Seoul National University Hospital in 1977, and he became a faculty member of the Department of Otolaryngology at the Seoul National University Hospital in 1983. He studied head and neck surgery for 2 years at Kwang University in Germany from 1985 to 1987. After return to Korea, he founded the Korea Society of Head and Neck Surgery in 1990. He was the president of the Fourth World Congress of IFNOS held in Seoul, Korea in 2010, and he retired from Seoul National University Hospital in 2013 and served at the Burmah Hospital in Seoul, which is one of the affiliated hospital of the Seoul National University until 2017. And currently he is working at Bongdae Johnson General Hospital. Today, Dr. Kyung-Won Kim's present topic is voice problem related to thyroid surgery. Please give it a round of applause to welcome Dr. Kyung-Won Kim.
Thank you very much for your kind introduction. So, shall I start my PowerPoint slides?
Yes.
The title of my lecture today is voice problem related to thyroid surgery. As just Dr. Kuo introduced me, I'm now working in Bundang Jaeseng Hospital since 2017. So already 8 years I'm working here.
You have to share your screen first. Share your screen.
Share screen. Oh, I did. It's okay?
You haven't shared the screen.
I did. 공유. Alright. Is it okay?
Yeah, you start to share the screen. Yes.
Yes.
All right. So, Dr. Hao, you remember this photo?
Yes, of course.
This is the first time I meet Dr. Hao in Taipei. It was in 2001 for the third East Asian Conference on Phonosurgery. And this is Dr. Myung-Hun Sung, who worked in Pittsburgh together with Dr. Hao for about 1 year, like that, in 1990s, yeah? So since then, Dr. Hao and I became a very close friend. Dr. Hao, you know, everybody knows that he founded the Asian Society of Head and Neck Oncology, ASHNO, in meeting in 2009. So the first Congress was held in Taipei in 2009, September. And there, Dr. Martin Myers and William Wei was there also. And our wives, my wife's not here, but some wives are here, also Pil Sang-chung and Myung-Hun Sung's wife. And the ASHNO meeting was held in Seoul in 2019. It was 6th ASHNO meeting in Seoul. Dr. Hao is serving as the Secretary General for ASHNO. And we are frequently meet in American Academy meeting, and this is 2019 AAO-HNS annual meeting in New Orleans. As you know, Dr. Myers had many international fellows. I was also fellow of the Dr. Myers, and I was the international guest lecturer on head and neck surgery in AAO, sponsored by Dr. Myers in 2002. And Dr. Hao was my lecturer in 2014. So I start my lecture on dysphonia related with thyroid surgery. There are 4 topics. The first one is pre-op or non-surgical voice change due to cancer invasion to the nerve. Second topic is recurrent laryngeal lobe injury during surgery. Third topic is the injury of the external branch of the superior laryngeal lobe. And the fourth topic is post-op dysphonia without nerve injury. So first topic, pre-op dysphonia. We have to consider about the situation. Usually the voice problem happens before surgery due to the recurrent laryngeal infiltration due to the invasive carcinoma. But sometimes the benign disease and or lymphomas also can improve on the voice. So in an invasive carcinoma, sometimes the pre-op function is normal. In the case, we have to preserve the recurrent laryngeal nerve. But if the nerve is completely paralyzed, we have to resect the recurrent laryngeal nerve. Is it meaningful to preserve the paralyzed lymph node is a question. It's definitely less whenever possible, because the intraoperative electric stimulation shows some muscle activity and the positive response after electric stimulation. It means that we can maintain the volume of the vocal fold. When we have to resect the recurrent laryngeal nerve, usually the re-innovation is definitely necessary, if possible, to restore neural connection to the larynx and restore motor tone of the thyroid tenoid muscle or lateral cricoid muscle to preserve volume and viscoelastic function of the vocal fold. Usually the re-innovation method is endotendon anastomosis. This is direct neuropathy and interposition nerve graft and the cervicalis hook-up technique and nerve muscle pedicle graft. Direct neuropathy endotendon anastomosis is first proposed by Dr. Horsley in 1909, very long time ago. It was usually done in trauma setting. And it is necessary adequate size of recurrent laryngeal lobe stump and adequate length of recurrent laryngeal lobe stump. Another technique is undercervicalis nerve anastomosis. Undercervical nerve is from hypoglossal nerve and connected to cervical plexus number 2 and number 3. And it sends the motor nerve branches to the strap muscles. So we can use the branch of these motor nerves to connect to the distal stump of the recurrent laryngeal nerve. Then we can get some motor function. Okay. This is a case of undercervicalis anastomosis. It's a 48 years old male, and he has a preoperative hoarseness. There was a hard mass on both thyroid gland, and it looks like suspicious parasite PTC on both sides. So 2008, total thyroidectomy with bilateral leg dissection was done. And left recurrent laryngeal lobe was invaded by thyroid cancer, so it was sacrificed. And endotendon anastomosis with undercervicalis was tried. So total thyroidectomy, the pathology result was a papillary carcinoma on both sides. There was the extrathyroid extension on left, and there were a lot of metastases, 23 out of 59 lymph nodes, a lot. So this is the operative finding. So A is the distal stump of recurrent laryngeal nerve. B is the main branch of undercervicalis nerve. This is the anastomosis side, C, this arrow. And D is the trachea. C is the inferior horn of thyroid cartilage. Okay. After the operation, this is the patient after operation. He's singing Korean anthem. Oh, so you hear the song? You know this song, Korean anthem?
Yes, yes.
He can sing very well. Okay.
Very good result.
Next topic is the postoperative vocal fold immobility is usually due to the iatrogenic injury of the recurrent laryngeal nerve. So usually the vocal fold is shaped like this, curving and shortening. The management for this situation, it's a similar management to the acute vocal fold paralysis. We need voice therapy, injection laryngoplasty, and framework surgery by Ishiki, and re-innovation surgery. So injection laryngoplasty was the oldest treatment method for vocal fold insufficiency. Originally, the paraffin was used, then silicone, pistol, bone dust, Teflon was used. Recently, the injection material is collagen, gel foam, silicone bead, hyaluronic acid, fat, fascia, calcium hydroxyapatite. There are various different kinds of the injection materials. The advantages of injection laryngoplasty, it's very easy to perform this transoral injection with fiber optic, and it's usually well tolerated by patients under local anesthesia. Sometimes I do it under general anesthesia also. No external scar. The good postoperative voice quality is also very good and less expensive than open surgery. And we can do it by percutaneous injection through cricothyroid muscle. And this is the vocal fold paralysis on the left side. It was done transcutaneously, and the vocal fold closure is almost complete. So this is the voice after injection laryngoplasty procedure. This is pre-procedure, pre-operative voice. The voice is very weak and hoarse. After surgery, yeah, his voice is much better. The third topic is injury of the external branch of the superior laryngeal nerve. You know, the symptom after external branch of superior nerve injury is usually weakness and easy fatigability during phonation, and the alteration of high pitch in singing and speech, and some hoarseness and swallowing discomfort, cough, and the neck pains. This lady is a very famous Italian operatic singer in 19th centuries, Amelita Galli-Cruci. She underwent thyroidectomy, and because of the external branch of the superior laryngeal nerve injury, she has to finish her career as a result of the injury. So the external branch of superior laryngeal nerve is called as the nerve of the Amelita Galli-Cruci. The frequency of this lesion is although difficult to assess, but varies from 14% to 20% of the cases. To prevent the injury of the external branch of the superior laryngeal nerve, you have to know the anatomical variation very well. This is the classification of variation, the type 1, type 2A, type 2B. Type 1 is the external branch is in front of the superior thyroid pore, so it's not passing under the thyroid gland. And 2A is the external branch is located a little bit posterior to the superior thyroid artery. But in 2A, the nerve is not under the thyroid gland. But in 2B, the external branch is passing posterior to the superior thyroid artery and passing under the superior thyroid pore. So distribution of type 2B of the external laryngeal nerve, which is this is a high risk of the injury. How we can manage the external branch of the superior laryngeal nerves? We may use the injection laryngoplasty in the severe cases. And Professor Ishiki also proposed some thyroplasties to improve the vocal fold tension and elevate vocal pitch, such as cricothyroid approximation. But I have not done this by myself. Topic 4 is postoperative dysphonia without nerve injury. Usually, vocal range profile at high pitch decreased by 25% during first 2 weeks after thyroidectomy, but gradually improved by time. So most of the cases, we do not necessarily to treat this. The causes of post-thyroidectomy dysphonia without nerve injury is the laryngotracheal fixation to skin. After skin elevation from the larynx and the thyroid gland, there are some fibrous fixation of the skin flap to the larynx and the trachea. And there were also stress muscle injury, external muscles, and the injury of the extrinsic perithyroidal neural plexus. And there may be some vocal fold edema by intubation. So I show a case of a lady, 61 years old at the time, in 2007. She had a long history of thyroid nodule, more than 20 years. Actually, this is my wife. So regular thyroid sonography follow-up was done. And 2007, there was some suspicious malignant nodule on the right side of the gland. And FNA shows also suspicious for papillary carcinoma. This is the CT scan of my wife at the time. There was some calcified nodule on the right side. But she had a very big goiter on the left side. So I did myself total thyroidectomy with neck dissection put to my wife. Pathology showed adenomatous goiter multiply on the right and left side with some articular follicular epithelial cells. And there were interstitial fibrosis and reactive hyperplasia. I did the neck dissection also, but there was no metastatic nose. And final pathology was not a cancer, just atypical cells. But she has a postoperative voice problem. She cannot make high tones. Actually, she was a good singer also, and she can go very high in singing. But after surgery, she is not singing anymore. So this is 5 years after surgery. But the next car is very nice. So the prevention of post-thyroidectomy dysphonia is also important. So intraoperative nerve monitoring is useful. Professor Peng Chang in Taiwan, he is a master of the intraoperative neuromonitoring and also the leader in this field. Intraoperative EMG can be used, but although it's not proven to definitely decrease the recurrent laryngeal nerve injury, but has some role to adjuvant tool to assist the surgeon in localizing the recurrent laryngeal nerve, in stimulating the nerve at the conclusion of the surgical procedure to document its integrity and function. So intraoperative recurrent laryngeal nerve monitoring by endotracheal tube electrode. The electrode is attached to the endotracheal tube at the vocal fold level and can pick up the signals of the vocal folds. There are some instruments for this. And also for external superior laryngeal nerve, external branch nerve monitoring, you can use this kind of EMG or nerve monitoring. To prevent the laryngotracheal fixation to skin flap, we have used some anti-adhesive drugs, patches, such as Gardix, Interseed, hyaluronic acid, carboxymethyl cellulose, like this kind of material. Gardix, I use it, and I think it's very effective. There are some postoperative methods to improve voice. It's a neck stretching protocol. The step one is to extend the neck stretching by extending and flexing. The step one. And step two is with some stress on the neck with the fingers. Step three is the neck stretching with the swallowing, and the step 4 is step 3 plus neck massage. So I have also performed this procedure for the post-operative dysphoneas. But the post-thyroidectomy dysphonia is the neck stretching and the massage is effective. In our experience, neck stretching did not show any statistically significant effect on recovery of the vocal range profile. So in conclusion, it must always be considered that voice complication can occur from various causes after thyroid surgery. Comprehensive multidimensional pre- and post-operative voice assessment is recommended for all patients undergoing thyroid and parasite surgery. Risk of voice impairment without nerve injury should be clearly explained to the patients, especially for professional voice users. Immediate management of recurrent radial nerve is also important and must be tried in case of nerve resection or injury. Oh, thank you very much. I finished a little bit earlier. We need some time to talk. Any questions? Okay.
Thank you, Dr. Kwang Kim, for this
I
very
need
comprehensive talk for voice problem after thyroid surgery. Now we open up to the floor for discussion. Is there any questions or discussion to make?
Hi.
Hi.
I'm Chen-Chi.
Yeah. I see
Thank you, Professor Kim, for a very nice talk. And according to your wonderful speech, I have a question for you, because there are also some other causes of voice problem after the thyroidectomy, including the laryngotracheal synechia to the skin flap or stress muscle injury. So we cannot totally prevent the voice disorder after the thyroidectomy. So do you routinely record the patient's voice before thyroidectomy, so we can know is the voice complaint subjective or objective? Do you suggest routinely record the voice of our thyroidectomy patient?
When I was in Seoul National University, I routinely checked the voice stroboscopy and also the voice profiles. Voice examination was done, but in this hospital, I'm not doing that now. And one other thing is I have to confess is that I'm not using intraoperative nerve monitoring for parotid surgery. I use the intraoperative neuro monitoring, but for thyroid surgery, I use only my eye.
Yeah, I believe your eye is one of the best monitor of the surgery. Thank you for your answer. Thank you. Yeah, because also in Taiwan, the national health insurance will not reimburse the cost of voice evaluation before the thyroidectomy if the patient does not have a voice problem before the surgery. So it is a little bit difficult to compare the voice after the surgery to the voice before the surgery. That's the reason why I asked this question. Thank you.
So you do nerve monitoring?
Yeah, I do nerve monitoring because it is popular, and usually most of the Taiwanese patient who is going to receive the thyroidectomy, they ask for this monitoring because probably the news and the patient's friend tell them this information.
Yeah.
Okay.
Is there any more questions? Is there any more questions? Chief Resident, can you post the webinar photo on the screen?
Post.
What photo?
No.
Not me.
The photo for the whole series, the Dr. Sheng-Po Ho retirement educational webinar.
Webinar.
Schedule.
Okay, I'll post this.
影片啊，
嗯，
以前的那个整理家也是整理那种很大的那种照片，我要存去哪里才不会
What? My
没空间啊？iCloud 好像没空间呢、是 Dropbox 吗？
你说哪里？
空间
who is talking now?
Hello, please post the my retirement.
Oh, okay. But my computer is
My lecture is the last one, yeah?
Yeah, your lecture is the last one, so I just want to post the.
你
Yes,
这边
please.
你这边帮我分享我电脑上。我已经允许。我允许。
有没有我的那个整个的那个照片啊？郭佑轩做的，郭佑轩做那一张海报。
好，等我一下哦，马上。电脑上。
So, Professor Kwang Kim, thank you for your wonderful lecture. I also cherish the friendship between you and me, and also yes, and also the friendship between the Korea and Taiwan, especially the head and neck surgeon, the Korean head and neck surgeon, and Taiwan head and neck surgeon. I think we have actually established the true friendships between the two countries, especially between the two head and neck societies together. And I also thank you for helping me, and also we together established the Asian Society of Head and Neck Oncology, which has been recognized as one of the representative head and neck societies for Asia in the world. And so today, this morning will be the last webinar for my retirement series. We start the series with my own mentor, Jim Miles from Pittsburgh. And then we finish the webinar with my best friend, Professor Kwang Kim from Korea. And it has been 35, I think it's 35 or 36. I think it's 35 webinars in 9 months. So I want to thank every speakers who join us for this webinar series, and we will put all the educational video on the YouTube, so that if you miss the webinar, you could record it anytime and watch it anytime, and learn from all the speakers or all the experts in the world. I will be stepping down from the department chair in 2 days later, January 1st. I will step down from the chair position. I've been the chair in different hospitals, different medical centers for around 28 years, and it has been just too long. So I would be very happy to step down. But before my retirement, I really thank all the friends from all over the world, including my own mentor, Jim Miles, and also some of the distinguished Miles lecturers, such as Professor Kwang Kim from Korea, to celebrate my retirement with me. So I thank you from my heart, deeply from my heart. Thank you so much for supporting me, and we will be good friends forever. Thank you.
Oh, thank you very much. Actually, we are brothers. I'm a big brother.
Yes, of course.
And congratulations for your retirement and Happy New Year. See you next year.
Yeah, and probably I will see you next week in Kaohsiung.
Yeah, 2 weeks later.
2 weeks later. I hope I could be there. And we have some drink together.
Okay.
All right. So and thank you for all the participants. That's the end. That's the last one for this webinar series. So thank you for your participation and goodbye. Bye. Have a good day.
Goodbye.
Bye. Bye.
My regards to Vivian.
Thank you. Congratulations to Professor Ho.
Yeah,
congratulations.
Yeah,
for
thank
your
you.
retirement.
Yeah, thank you.
Bye.
Bye.
Bye. Congratulations.
Yeah.
Okay.
Professor
I have to
Kim.
go to
Professor Kim, I actually forgot. I think it should be tomorrow. So I actually forgot. I remember you were going to talk as the last one, but I actually forgot this this morning. I just forgot. But I just get in time. So nice to see you. And
very, very nice to see you. Okay, see you tomorrow. See you next year.
All right.
So, bye. I'm going out.
Keep safe and have a good day. All right. Bye now.
Bye.
Yeah. And say hello to your wife. I did not know. In her neck, there is any scar. I did not see it. So congratulations on your good work. All right. Bye.
Okay. Bye.
Bye.
I go out.
Yeah. Thank you.
Thank you. Bye.
Bye.